Greetings, I'm Dr. Pang Hong Wu from Ng Teng Fong General Hospital, Singapore. This project is in collaboration with Dr. Hyu Song Kim from Nanori Hospital, South Korea, on a comparatively clinical and radiological cohort study of unilateral thoracic endoscopic laminotomy bilateral decompression using one-block resection technique and thoracic open laminotomy with bilateral decompression for thoracic OLF. We have no conflict of interest. Thoracic OLF is an uncommon cause of thoracic myelopathy. Open surgery is generally recommended with symptomatic thoracic myelopathy. Endoscopic spine surgery has improved instruments optics and provides solution for lumbar and thoracic region. There's paucity of literature in comparative interventional cohort study between open versus endoscopic. We have done a evaluation in terms of clinical results and radiological imaging of MRI for these two groups. This material methods wise, we did a retrospective comparative interventional cohort study with patients who are included with JOA score of less than or equal to 10. We did preoperative CT, MRI, and clinical evaluation in terms of VAS, ODI, JOA score, and MAGNEP score in the interval of 1 week, 6 months, and final follow-up. We've included 35 levels of endoscopic and 24 levels of open surgery. In terms of results, we find that there's no difference in terms of age and sex. There's a shorter follow-up in the endoscopic group, and they have less complication in the endoscopic group as well. There's a VAS, and in terms of VAS, ODI, and JOA score, clinically, there's statistically significant improvement in both groups of patients. And comparing the two group techniques, endoscopy does better in terms of JOA score and final VAS statistically significant. This is a picture showing the radiological results and a surgical video showing our technique. In the 3 o'clock position, there's T10, caudolaminar, and in the 9 o'clock position is our cephalic lamina of T9. In the 6 o'clock position is ipsilateral side. We did start our drilling, endoscopic drilling at the laminophaseal junction at the ipsilateral side. We move towards the cephalic lamina, carefully doing a laminotomy. And we do the over-the-top decompression of contralateral cephalic lamina. Subsequently, we also do endoscopic drilling of the caudolaminar, ipsilateral, and contralateral side, all in the attempt to thin out as well as delineate the lateral aspect of the ossified ligamentum flavum. When it is sufficiently thin, you can see a thin layer of the epidural space, and we can lift up the entire single block of OLF in one piece. In this case, we did some final trimming with a Kerrison ronger. These are the intraoperative pictures showing good decompression of the thoracic dura. And on a good specimen, we can take the entire block of OLF. In our conclusion, we find that in experienced hand, endoscopic decompression can be considered as an option for surgical treatment for symptomatic OLF, despite the steep learning curve of endoscopic spine surgery. We welcome any questions. Thanks for listening in.